Welcome to Omega Matters, where we talk about all things Omegas. I'm Kristina Jackson. This is Bill Harris. And today we're welcoming back Dr. James O'Keefe. He's a preventative cardiologist at St. Luke's Hospital in Kansas City. He's also the director of the Duboc Cardio Health and Wellness Center and director of preventative cardiology at St. Luke's in Kansas City and the Mid-America Heart Institute. And he's joined the Fatty Acid Research. Am I saying those Duboc? Is that right?
Yeah, that's it, Duboc.
Okay.
That's French pronunciation.
Yeah.
Well, I guess the French pronunciation might be Duboc, but
Right.
Throw an extra letter, why not?
I know. James has also joined the Fatty Acid Research Institute to dig deeper into some of the questions he encounters in the clinic. In addition to that, he's an excellent communicator, regular on Dr. Radio, has been on The Drive, Peter Attia's podcast, and has given several TED Talks and written books. So today we're going to talk about some of the research Dr. O'Keefe did with FARI around omega-3s and stroke. So welcome back, and thanks for coming on to talk about this paper.
Thanks, Kristina. It's fun to be discussing this topic with you and your father, Bill, the Codfather.
And I think, well, the last time I saw you, we were at a conference in France.
Yeah.
And I believe you did do a presentation about this topic, but the paper wasn't quite published yet. Is
Right.
that right? Yeah.
Yep.
It was great to have that conference in person again. I think that was the first time since COVID. So that helps.
Delightful spot, Nantes. Right?
Nantes. I never say it right. Again with the French.
Yeah.
I can't say French words very well. So this paper we're going to talk about is about stroke and omega-3s, and I'm going to let you guys kind of take off on why you decided to do this study.
Well, yeah. What do you think? Why do we care about omega-3 and stroke?
Well, stroke, like dementia, these things that incapacitate us mentally are, understandably among our biggest fears for most people, along up there with cancer, and like heart disease, it's still the #1 killer, but people aren't that afraid of it, maybe because it's manageable and whatnot. Like, but you start talking about stroke and ending up, in a wheelchair and a diaper, can't talk, that gets their attention. And stroke still is among the leading causes of death and disability worldwide, in the top 2 or 3 causes, because, it can be so catastrophic. And the thing is that, we've made a lot of progress. It's, controlling blood pressure and diabetes and not smoking, but and reducing LDL cholesterol in people that have atherosclerotic cardiovascular disease. We like to, abbreviate ASCVD. But there's, a lot of biologic plausibility that you and I know about and have been writing about and talking about and doing papers on for decades, why omega-3 might reduce risk of stroke. Bill, you probably could, touch on those, right? The effects.
You mentioned an interesting thing there. Are the risk factors for stroke the same as they are for heart attacks?
Not exactly, because there's a subset of strokes that's hemorrhagic stroke, and that is not due to atherosclerotic cardiovascular disease. #1, the lion's share of strokes are due to ASCVD, but then there's also another substantial part of strokes, ischemic strokes, that are due to embolic phenomenon like atrial fibrillation, a really important and growing cause of stroke. So so they overlap substantially, hypertension, dyslipidemia, smoking, obesity, sleep apnea, family history, these kinds of things that we really focus on a lot in the general field of preventive cardiology. But there's a saying that goes something like, what's good for the heart is good for the brain. There's huge overlap here, and it's certainly true with omega-3, as it turns out. This study is a case in point on that. Yeah.
Well, you mentioned AFib. there's been some noise about AFib in the omega-3 world lately. Did this paper play into that at all?
Yeah, it sure does. It was one of the reasons you and I decided to really do this study, is because there was, there's this very complex and nuanced issue about the effect of omega-3 on atrial fibrillation. And probably at high doses, like pharmacologic doses, 2, 3, 4 grams a day of EPA plus DHA, we see an increased risk of atrial fibrillation, probably because in part due to augmented vagal tone and bradycardia and in susceptible people like folks who have sick sinus syndrome and slow heart rates, or untreated sleep apnea, or athletes who are doing very large volumes of endurance exercise. But the thing is that atrial fibrillation, that low dose omega-3 probably reduces risk of atrial fibrillation, which is just really complex. And most people don't know what to make of omega-3 anyway, and then you put this nuanced thing. But we have a paper in press right now, looking at that and explaining it. It's probably low dose vagal stimulation is antiarrhythmic. It prevents sudden death. It reduces risk of atrial fibrillation, and it improves health and well-being. And I mean, it's good to have high vagal tone, but really high vagal tone can cause a trouble, especially in susceptible people. And that's why you probably see this biphasic, bidirectional, dose-dependent risk of atrial fibrillation. But in any event, the dreaded side effect consequence of atrial fibrillation is stroke. And these are big strokes. The left atrial appendage is about the size of your little finger, and so when you go into atrial fibrillation and the atria become they're basically just sitting and quivering and not contracting, you get stagnant blood in this nook and crannies of the atria, like the left atrial appendage, and these these clots can form that are like a centimeter big, and when they flip out of there, about 20 or 25% of the blood goes to the brain, and this clot gets filtered out in the brain, and it's like a really, really catastrophic stroke. So atrial fibrillation, for good reason, is, and we've seen it more and more all the time, with an aging demographic and more obesity and diabetes and sleep apnea. I mean, atrial fibrillation, our hospital service is full of it. So so you'd guess that you might surmise that if omega-3, high dose omega-3 increases risk of atrial fibrillation, then it would increase risk of stroke too. But that's not what we found. We found the opposite. So, there's, when you see paradoxes in nature, lots of times that's like a key to like unlocking important knowledge that we hadn't appreciated before. And I think this, this sort of like is an unfolding story that I think is really important.
Yeah, and I needed to jump in and say the name of the paper so people know where to go find this and what we're talking about as we get into the nitty-gritty. So the paper was published in the journal Stroke, and it's entitled Omega-3 Blood Levels and Stroke Risk, a Pooled and Harmonized Analysis of 183,291 participants from 29 prospective studies. So we've already kind of covered stroke and the severity of it and the risk factors, and why you guys really wanted to look at the relationship between omega-3 blood levels and actual stroke, the outcome that is even more severe than AFib. So how did you go about answering this question, finding out if there is a relationship between higher blood levels and risk for stroke?
Yeah, the blood levels of omega-3, particularly EPA and DHA, which are marine omega-3s that you really can only get by swallowing them. These are not, I mean, we can make small quantities of them from the ALA, alpha-linolenic acid, but for the most part, this is a function of dietary and supplement, or there's the drug versions of omega-3 too. There's 2 or 3 branded omega-3 products for real high dose, usually used for triglyceride lowering. But but the point is that the levels of these correlate really strongly with outcomes. And Bill and I were just talking about this the other day. Lots of times you can give the same, two different people the same dose of omega-3, and it'll have very different effects on their levels of omega-3. And we're finding that it's the levels that really correlate with the improved outcomes and the changes in biology. So we looked at, and this is a consortium, the FORCE consortium that Bill put together along with Dariush Mozaffarian. And it's about 60 different centers that have, prospective ongoing observational studies where they have baseline levels of omega-3. And then like in this instance, 29 of the centers had data that was available and pertinent to this study. And then we had like 14 years of follow-up. So it's really, really powerful data. I mean, you got 183,000 people followed for 14 years, and you look back on their baseline omega-3 level and correlate it with things like the risk of stroke, the ischemic stroke, where your vessel is blocked off, or hemorrhagic stroke, which is about, as I mentioned earlier, about 10% of strokes are caused by bleeding into the brain, where a blood vessel ruptures. That goes along with other things like, uncontrolled hypertension or bleeding abnormalities or inherent aneurysms in the brain. But in any event, we looked at this, and because there's many different ways to measure omega-3 levels, we basically standardized these 29 trials by breaking the EPA and DHA and total omega-3, EPA plus DHA, into quintiles. So the people in the top quintile had the highest omega-3 levels, and the quintile 1 the lowest, and then we correlated outcomes based on the quintiles. And I don't know if we can show the the figures from the study, but they are pretty striking. The quintiles show a dose-dependent reduction in risk of stroke, ischemic stroke in particular, with about a 17 to 18% reduction in ischemic stroke in the top quintile compared to the lowest quintile. And the hemorrhagic stroke really showed no effect. The quintile, the highest quintile versus the lowest quintile, there was no statistically significant change in risk of hemorrhagic stroke. So we think that it's like it's without question the largest, most comprehensive observational epidemiological study looking at the question of omega-3 levels in stroke, and it came up with pretty darned unequivocal results suggesting that a higher level of omega-3 is associated with a lower risk of stroke.
And was the highest quintile, I guess, at least for the red blood cell, maybe you're going to be showing some things. What omega-3 index was that about? Was that about 8%?
Bill, do you want to chime in on that?
Yeah.
Yeah. And I think we're not sure we did it in this study, but I know we did it on the total mortality study, which is the same general idea, the same group of studies. Yeah, and I believe the top quintile was roughly 7.8% omega-3 index. So
that's
8%.
Average.
Yeah, was it the average or the median? One of the two.
Yeah. Okay.
Yeah. So here's
the lowest quintile would be about 3% or 3.5%.
Yeah, 3.5. Below 4 and around 8. Yeah, so it's kind of as we proposed 20 years ago. Those markers seem to be the extremes.
Mm-hmm.
And the average adult in America, I believe, has an omega index of about 5.3 or 5.2.
Yeah, between 5 and 6.
Mm-hmm.
Okay,
somewhere in that area.
And so you can see there's a lot of room for improvement here. I think 90% of people in America, right, are not in that top quintile. Or, I mean, I guess based on this study, you'd say 80% of the people aren't in that top quintile, because by definition, these are the highest 20% of people. But yeah, if we use 8%, I mean, it does seem like a really sort of solid number that keeps coming up, and it's about the average omega index for Japanese population, for example, which has a very high intake of fish and seafood, and also a very low incidence of ASCVD events. They do have a higher stroke risk traditionally, but it was because of high smoking rates and uncontrolled hypertension from too much salt in the diet. But their stroke risk has been coming down in the last 2 decades substantially as they cut back on smoking and control their blood pressure.
Are you all seeing this figure from the paper?
Yeah.
Okay.
Mhm.
Can you explain this to the watcher, James?
Well, it just shows that, that this is a forest plot where a neutral risk would be right on that vertical line in the middle. And so that'd be the reference list, and that would be the quintile 1. And then going to the left, that's a reduction in risk. And you can see that the reduced risk is for total stroke down to Q4 and Q5 are about the same there, the same reduction. And then ischemic stroke is where you see that even a little bit more because that's where the action is. That's what the omega-3 does. It reduces ischemic stroke, and it doesn't reduce the hemorrhagic stroke, but it doesn't increase it either. But you can just see again that you'd want to be in the 4th or 5th quintile to get the full benefit there on that.
Yeah, and so that last set, the hemorrhagic stroke, the estimates are for benefit actually down there 0.9 roughly. It's just that there's so few of them, these hemorrhagic, like you said, like 10% of strokes
Yep.
are hemorrhagic. Yeah, in this study, the number of people was small, so we have a wide confidence band, and we have to say non-significant. But certainly the trend is for improvement in risk, which is, why is that comforting particularly? I mean, was there something?
Well, as you know, the first sort of hints that omega-3 are good for your heart came from the Greenland Eskimos with Bang and Dyerson publishing that article in the New England Journal of Medicine probably 50 years ago or more. And they noted that there was these Eskimos which had the high levels of these unusual fatty acids, the EPA and DHA. They weren't really household names, but at that point, that they had a markedly reduced risk of myocardial infarction. They just didn't really see coronary disease in this population, but they did see strokes actually. Now, these Eskimos, you can correct me, Bill, but I believe they were consuming upwards of 15 or 20 grams of EPA plus DHA per day.
Well, no, I actually wasn't quite that bad or that much. I think it was like 7 or 8 in one of the Dyerberg and Bang's paper, but still, that's
the average American consumes 100. The average American consumes 100 milligrams. So
milligrams, right? So
100 milligrams.
And of course, the Eskimo lifestyle, it ain't all about omega-3. I mean, smoking, exercise, not good. Yeah, a lot of things, infections, and anyway. So
but they had some increased
bleeding
risk of death from hemorrhagic stroke, and so we were worried about that. And omega-3 does have some anti-clotting mechanisms. It reduces platelet aggregability, and it it can increase risk of bleeding, especially especially even at modest doses at 1,000 or 2,000 milligrams a day of EPA plus DHA. Especially if you're taking it with aspirin, it can increase bruising after, like, say, getting your blood drawn or bumping into something. But yeah, we don't really at doses. I mean, I think, Bill, you did a paper that said that you don't really see pathologic bleeding with omega-3 until you get into the 7,000 milligrams a day. Is that about right?
Something like that. I think that's where right. And even the package insert for Lovesa and Vascepa say there's no increased risk for clinically significant bleeding from omega-3, even when you're taking blood thinners.
Yeah. Well, and there's that OPERA study, which is a randomized trial of omega-3 for trying to prevent AFib around the time of open heart surgery. It was neutral with respect to that. They used about 2,000 milligrams of EPA plus DHA, and it was a sizable study. I think it was like 700 people, and they saw like a substantial reduction in need for transfusion and like real serious bleeding in the people that got the omega-3 around the time of surgery. It's very counterintuitive, and full disclosure, we don't recommend high dose omega-3 preoperatively. In fact, most surgeons insist on holding the omega-3 for a week or two before surgery, but I think that's probably not really warranted, but
Yeah, I agree.
Kind of a superstition.
Yeah.
Mhm.
Well, as we kind of wrap this up, or do you think this new paper on stroke is going to move the needle in the cardiology community?
I think it's probably the most compelling data out there. It's an observational study, so you can't really draw firm conclusions on causation. But on the other hand, as you know, like the REDUCE-IT study, which used 4 grams of EPA, about 4 grams, in people with high risk for ASCVD, it reduced overall MI, stroke, and cardiovascular death by about 26%. And if you look specifically at the stroke, it reduced it about 29% or so. And strangely, it also in that study increased risk of atrial fibrillation. The 4 grams of EPA increased the risk of atrial fibrillation like by 30% or 35%. And the meta-analysis shows that it does too at high doses. At 1 gram of EPA plus DHA, there might be a marginal increase or probably a neutral effect. Our observational, meta-analysis of observational study, pooled analysis in the forest showed that at 600 milligrams a day, 600 or 700 milligrams a day, there was actually a small reduction in risk of atrial fibrillation. I think it was about 15% or so.
Yeah.
But in other words, there's prospective randomized controlled data showing that it looks like it reduces risk of stroke as well. There's a lot of other reasons to take omega-3. Getting back to the brain benefits. I mean, I think Bill, you did a study, observational study on the Framingham cohort showing that high DHA intake, being in the top quintile or so, was correlated with like a 49% reduction in Alzheimer's disease.
Yeah. Right.
Yeah. And again, the biological plausibility is good. I mean, they have anti-inflammatory effects, which is good for the arteries and good for the brain. We talked about the antiplatelet effects. They reduce triglycerides. They have they also are a really important component of the cell membranes, and the cells that are electrically sort of based, like the neurons and the myocardial cells, would be especially the ones that you'd expect to benefit from, like getting those DHA levels, especially, and to a lesser extent EPA levels, up to replete good high levels to kind of just improve membrane performance and communications between cell to cell, and pliability and resilience. And there are good studies showing that omega-3 levels correlate quite strongly inversely with brain shrinkage with age. That if you want a nice, plump, healthy, youthful brain, you want to keep your omega-3 levels high. The people with Alzheimer's and other causes of dementia, like multi-infarct dementia, tend to have shriveled up brains, which is definitely not ideal.
Yeah. Hopefully we can get into that one of these days. Anything else, Tina, we wanted to talk about?
I guess to finish up, we aren't doing medical advice here. We're talking research, but it's still kind of a complicated story. So how do you talk to your patients about omega-3s generally?
Well, I mean, one of the things that Bill and I were just talking about this week is that, this study does emphasize the importance of like knowing your level. This is a simple test, and Omega Quant is, in my opinion, the gold standard for knowing that, whether you're a young woman who's thinking about getting pregnant or are pregnant, or you're somebody with heart disease or high triglycerides, or somebody who wants to avoid a stroke, or know what your levels are. And if you're like your average American, like you need to be taking probably 1,000 milligrams a day of EPA plus DHA, or if you're in the lowest quintile, more like 1,600 milligrams of EPA plus DHA per day. I think there's a lot of good reasons for that. And my wife Joan is a smart dietitian, and one of her missions in life is to get to improve mental health by just getting the omega-3 levels up to normal. She argues that you don't even know what, like, there's all sorts of people who are depressed or, or angry or, forgetful or all sorts of things. And the mental health in America has like almost never been worse, since the pandemic and all this, rhetoric and, confrontational, all this antagonism, you don't there's really good studies showing that things like mood, and we're doing a study right now, show correlating omega-3 levels inversely with suicide and suicidal ideation. So you don't even know if a brain works well until you get the omega-3 levels up there, and that's good for mental function. It's good for reducing cardiovascular risk, reducing stroke risk. It probably is associated with lower Alzheimer's, and there's just and it's inexpensive. But interestingly, like in the randomized trials, actually the levels attained are more predictive of good outcomes than the therapy assigned.
That makes
some people don't take it, some people don't absorb it. I mean, whatever else, it's like this is kind of like blood pressure. You don't just like give somebody a blood pressure med and say, okay, you're good now. You need to know that the level you're shooting for is where you're at. And that's why I think with the Omega Quant, know what your level is, get it up to 8%. And, like I take omega-3, I eat fish most days. And like in recent years, I've been like increasingly eating like a Mediterranean diet that's real high in healthy fat, like extra virgin olive oil, Italian polyphenols, and lots of nuts and lots of avocados and fatty fish. And my omega omega index was like 11% or something. But then it started dropping, and I realized I had to increase my omega-3 intake just because and I don't know, Bill, if you've seen this before, but I think it's because I eat such a diet that's high in fat. I mean, it's good fat. I don't eat a lot of saturated fat, but I think it's just a matter of like balancing off all that other fat that's not omega-3. And so in any event, I'm taking more omega-3 now than I was before. I take about 2,000 milligrams a day.
Yeah. So your index is up around 10 or 11%.
Yeah, it's traditionally been between 9 and 11%, and the last one was more like 8%. Yeah.
Yeah. I mean, that's all. It's all.
Where do you keep your
job.
guys' levels?
Mine bounces.
I'm around 10. I hope. I just did another test today. I'll find out. It's been a while.
Yeah, I haven't tested in a bit, but I'll be at 8, between 6 and 8, depending if I've forgotten my supplements. Like if I run out of them, that's what happens, and then I drop. Remember to get them, and then gets back
Well,
up.
I was getting, being a cardiologist, I'm sort of like a cardiac neurotic, and I can feel my heart beating, and so I was noticing some premature atrial contractions, which irritable beats from the top of the heart, and so I got all checked out from one of my colleagues and stuff. My heart's fine, but I do exercise a lot, and I'm sort of like one of those like poster boy for somebody who could get the atrial fibrillation for too much exercise. And so I was thinking the real high dose omega-3 would be aggravating that potentially. And so then I stopped taking my omega-3 for a while, and then and went down to, despite eating fish like like a Japanese person, I mean, my omega-3 level went down to like 6.6 or something, so I got back on omega-3, and now it's back above 8. But it's a good example of like how to use the omega index. It's not like it's like blood pressure. It's not a one-time check. It's like you need to follow it. It can change.
Yeah, it changes. You say it's moves slowly, but it still does move. And I think also just what we're talking about today is you can potentially be too high, or there are some consequences of supplementing without knowing what you're at. And you want to get enough to get to a good level, but you don't need to go way beyond that, basically. So
yeah, there's a popular female podcaster, which we won't name by name, but I think she was bragging about an omega index of like 16 or something like that, 15 or 16, and I'm just thinking, like, in biology, most things in biology, like you want to be in sort of the middle of the normal range. And when you define normal as healthy, fully functional, healthy people. The problem with the most labs in America is they take an average of, generally unhealthy people. But if you get an average of healthy people, like on a sort of a Paleolithic diet, like our ancestors would have eaten for hundreds of thousands of years, I think you'd have an omega index of 8 or 9 or something like that. And so I think that's a good target. It's like there's not much in biology where if a little is good, a lot is best.
Right.
Almost anything, it's not a straight line, monotonic relationship.
Yeah,
Bell curve. Great.
that's it. Well,
Okay.
great. Thank you so much for coming on and talking about this paper and for working with Bari to do research and also practice. It's a really, really great partnership. So thank you so much for coming on again.
Yeah, well, thanks, Kristina and Bill. It's like a personal passion besides a professional passion. I'm just totally honored and thrilled to be working with you guys. It's just a real joy.
It's great to have you. Great to have you. We
All
started
right.
together 30 years ago or something. Let's keep it.
That's right. Yeah, we've been collaborating for a long time. And I mean, honestly, this is the best ever. The stuff we're doing right now is, in my opinion, like so important and still it's surprisingly, it's still a controversial topic. And I think we're out there.
No controversy, there's nothing to do.
That's true.
Yeah.
All right, James. Thanks a lot.
Yeah, my pleasure. Thanks. Okay.
Bye-bye.
Bye-bye.